Alright, so this is a lecture about community-acquired pneumonia. We're going to go through pathogenesis, microbiology, manifestations as well. So, for community-acquired pneumonia, think to yourself, what are your typical bugs? And usually they're kind of put into two different categories, right? The first category is your typicals. Now, your typical bugs are things that usually live in the nasopharynx. So, not only do they cause pneumonia, usually by microaspiration. They may also cause things like otitis media, even penetrate into the nasopharynx to cause meningitis. So that's kind of where these live. The bugs that you think about most commonly is going to be your strep pneumo, H. flu, Moraxella, and then in some cases MSSA. All right, so remember they live in the nasopharynx. They get into your lungs really by microaspiration. All typicals is either macroaspiration or microaspiration. Next, you're going to think about your atypicals, which truthfully is not the best classification system. I think it's more classified based on how you treat these organisms than from any pathogenesis or microbiology. One thing that they do all have in common is that these ones are more likely to be inhaled. Classically, they cause, since they're inhaled, they call more of a bilateral interstitial pneumonia, walking pneumonia. Usually it's kind of subacute in presentation, may present in young patients, but not every single atypical acts like that, so it's not something you can exactly hang your hat on. Ones that you would think about here are going to be Mycoplasma pneumoniae, Chlamydophila pneumonia, and lastly, and this is kind of why I said not all of them act like that, is Legionella, which can be a lobar pneumonia. Patients can be very, very ill with this. So like I said, atypicals are more classified by how they're treated than exactly how they present, meaning that you can't withhold a atypical treatment just because something presents like a quote-unquote typical pneumonia. Okay, so lastly, bugs that you do see every once in a while are going to be your multi-drug resistant organisms, right? So that's going to be your MRSA and your Pseudomonas. So when you treat both of these, or when you consider covering both of these, well, if you have you don't cover them routinely, but only if you have a high risk for covering both of those. So the way you cover both Pseudomonas and MRSA is going to be if the patient's severe sepsis. So if you're facing severe sepsis, you kind of have to cover MRSA and Pseudomonas by guidelines anyway. And next one, if the patient has antibiotics in the last 90 days. So always ask your patients, did they get antibiotics? Where were they? Especially if they're hospitalized and they got broad spectrum antibiotics, that makes it even much more concerning. All right, so MRSA, what are some of our reasons that we need to cover MRSA? I'll say basically two: increased suspicion. So if it's presenting like a MRSA pneumonia, if it's cavitary, if there's an empyema, if it's post-viral, especially post-flu, that might increase your suspicion. If they've had as well gram-positive cocci on the gram stain or sputum, that's going to concern you too. All right, then high risk. High risk is going to be your next one. Are they high risk from MRSA? This is depending on where you look, but things that you might see patients that are high risk MRSA would be patients with IV opioid use disorder, maybe patients with ESRD, maybe patients with immunosuppression as well. Maybe sometimes wrestlers get thrown in there as well. All right, so that's MRSA. And then lastly is when by itself do we cover Pseudomonas? This one I'll say is increased suspicion. Mostly if you see gram negatives on your sputum stain, you really have to cover Pseudomonas. And lastly, just like MRSA, are they high risk for Pseudomonas? Patients that are really high risk for Pseudomonas, just like MRSA in the past, have they had Pseudomonas in the past, or really drug-resistant organisms in the past? Do they have bronchiectasis? Patients with bronchiectasis are much more likely to be colonized by Pseudomonas. Or do they have really severe COPD with recurrent treatment with steroids? These are all high-risk patients that you're going to need to cover Pseudomonas with. Diagnosis, honestly, of CAP is tough, and there's a lot of things that can present similar to CAP, and there's so much, diagnostic entropy nowadays with patients presenting so sick to the hospital with so many different comorbidities and sickness. But really, it is relying on clinical presentation. Does the patient have abnormal vitals, fevers, chills, leukocytosis? Do they have crackles, bronchi? Do they have abnormal breath sounds on their lung exam? Plus radiographic. And what you're looking for is a chest X-ray. Surprisingly, chest X-rays for pneumonia, the sensitivity are in the literature about 60%, so you may actually miss 40% of pneumonias if you're just looking at the X-ray, which gets us to inpatient CAP and subsequent workup. All right. So this is always a question, but when do you do further imaging? When do you do a CT scan? And so CT scan, not routine. So do not do it routinely. It does not help, but there definitely is sometimes where CT scans can be helpful for the subsequent diagnosis of CAP, right? So if you have a negative chest X-ray and you have increased suspicion, right, you probably want to really make sure that the patient has pneumonia, especially if you have increased suspicions for something like COVID or something like anthrax, something kind of rare that the CT scan might help. COVID specifically is usually ground glass opacity, so the chest X-ray really a lot of times does not pick that up. Next one is going to be neutropenic fever. Neutropenic fever, a lot of times they do not have neutrophils, so they can't mount an immune response. They can't really mount infiltrates on your X-ray, which a lot of times is neutrophilic inflammation, so CT scans can be more sensitive. And, if someone has complications, you're concerned about an abscess, empyema, if they're not getting better after 48 hours of treatment, very, very reasonable to consider a CT scan. Next is going to be testing for pathogen. I'm going to teach you ISA and also MixAB guidelines. If you look at up to date, this might actually be a little bit different. So things that you always check is going to be every hospitalization, HIV. All right. So not only does HIV put you at other opportunistic infections that expand your differential, it actually just puts you at higher risk for developing pneumonia as well. COVID, flu. COVID always, flu for the next season. Blood cultures if the patient's pretty ill. And then lastly, I'll say plus minus on your MRSA nasal swab. And then plus minus on your strep pneumo antigen, Legionella antigen, and plus minus on the sputum. So when you check these things, ISA guidelines mostly if the patient has severe pneumonia. For the sputum, if you're concerned about MRSA or pseudomonas, you should check that. For strep pneumo and Legionella, mostly severe, or if you really do have a high suspicion for Legionella. So this is more in the ICU. Up to date's a little bit more lenient. It says check it for everyone. I don't mind if it's checked for everyone. I think making the diagnosis is important itself, especially in patients where is it pneumonia, is it heart failure? You're still trying to make that diagnosis. I think these things can be helpful. Non-routine, a little bit controversial, is going to be procalcitonin. There's some literature that it does help differentiate heart failure versus pneumonia. So if you're trying to increase the probability of one or the other, that could be helpful for you. When to check a viral respiratory panel. This is only if you can really treat whatever virus it is, and you're more likely to treat something like RSV or adenovirus if the patient is severe, or if they're immunosuppressed. Lastly is bronch. When do we think about bronchoscopy and a palm consult? I think really for this, if you're not sure what the cause is, especially if the patient's severely immunosuppressed, we have opportunistic infections on the differential, fungal, TB, PCP. These are all indications for bronchoscopy, or as well if you're treating for CAP and it's not improving, other things, diffuse proliferative lung diseases like COP, BOOP, eosinophilic pneumonias can all look like pneumonia, reasonable to check as well. So that gets to our last part. Is what is going to be our outpatient CAP treatment. So no comorbidities, and I'm going by MixAB IDSA here. No comorbidities. You have really two treatment options. One is going to be that high dose amoxicillin. Now you kind of see it covers typicals, so I got in blue. It doesn't cover atypicals as well, but your thought is that the patient doesn't have comorbidities. If it is an atypical pneumonia, it will probably get better. Or another one that you can think about is going to be your doxycycline. All right, now doxy around us doesn't cover your typical pneumonias that well, so maybe not be the best choice. But these are going to be your choices for treating a patient with no comorbidities. When you get to comorbidities, age above 65, cardiopulmonary disease, you really want to divide typicals and atypicals, and you want to treat them with something that's going to cover for both. Specifically for typicals, you're going to want to use not just amoxicillin, but amoxicillin and clavulanate together here. And the reason why is that more Marexella, H-Flow, they can have beta-lactamases, so you want to add on that clavulanate to cover beta-lactamases. Beta-lactamase positive Marexella H-Flow MSZ that could be prevalent in this community. Plus, you guessed it, the other one is going to be something we use pretty commonly. That's going to be azithromycin. Can use doxy if, let's say, they have a long QT, but azithromycin is going to be usually go-to. You're going to cover your typicals and your atypicals. Now, lastly, we're going to get to all patients. How do you do inpatient CAP treatment? And this is going to be a PSA score greater than 0, and they usually need to go to the hospital to get treatment. All patients, you're going to cover your atypicals and atypicals, right? So your typicals, you're going to cover ceftriaxone. And then, once again, for your atypicals, you're going to do azithromycin. Okay? If they have some of the risk factors that we send over to the right, we're going to give these patients add on vancomycin. You can also use linezolid, but vancomycin is probably the more common. Daptomycin also covers MRSA, but always remember that typical question is inactivated by lung surfactant, so you can't exactly use daptomycin. Now, if they do have pseudomonal risk factors, I think guidelines, depends on where you look for this one, but I'll teach you the double coverage guidelines that sometimes used. So you want to cover something that covers typicals, so you're going to use a cephalosporin. So in this case, we're going to use cefepime because cefepime also covers your typicals just like ceftriaxone, but the one extra thing you're going to get on top of this is covering for that Pseudomonas. And lastly, and this is a little bit nuanced, but you can double cover for Pseudomonas in some of these situations. In that case, you're going to use something that covers atypicals and Pseudomonas at the same time, and that's going to be levofloxacin. All right. Lastly, anaerobic coverage. IDSA guidelines says not, if someone just aspirated and they got pneumonia, probably you don't need to specifically cover for anaerobes. UpToDate does mention that if you really have suspicion for it, terrible teeth, fetid breath, terrible breath, you might still consider coverage. But the really guideline-based time to cover for anaerobic coverage is going to be abscess. So pulmonary abscess can a lot of times have anaerobes there. And then lastly, something that's missed a decent amount is going to be empyema. Now, if you're using a cephalosporin-based therapy, you can add on metronidazole in these cases. When you consider adding steroids, just for CAP, this one's a little nuanced, a little bit new, but anything really once they're above high flow nasal cannula, or I'll say, actually in a better way to say this, anything above non-invasive ventilation. It may be damaging for patients, a little bit more patients to start them on steroids that have flu. You don't want to use it if they have influenza. It's been shown that it worsens outcomes in influenza. Fungal diseases probably worsens outcomes as well. And lastly, if they're immunosuppressive, it get a little bit tricky. But you can consider adding steroids in your normal immunocompetent patient with CAP if they're on non-invasive ventilation. And when you think about follow-up imaging, your concern here is, do they actually have a malignancy, maybe a post-obstructive pneumonia? I will say here, if they do have a concern for cancer, maybe they have recurrent pneumonias in the same spot, and you're worried about post-obstructive pneumonia, maybe they have in the background, red flags for cancer, you definitely want to do some follow-up imaging. And lastly, per guidelines as well, what is their smoking history? Do they kind of meet that criteria for a low-dose lung CT? If they do, they'll do a low-dose lung CT and follow up the guidelines for lung cancer prevention in the patient that is a smoker. All right, so that's everything for CAP. Thanks everybody for watching.